Coming to BSV, it's an important and fascinating topic. BSV is achieved by use of two eyes together. So that's the difference between a rat and us. So rat will have two eyes on the different area, and they will cover a lot of areas because they have to run. But for us, we have to do all skillful movements. That's why we have binocular single vision. So binocular single vision is achieved by use of two eyes together. By the slightly dissimilar images arising in each eye are appreciated as a single image. That's where the point is. So grades are three grades. First is simultaneous macular perception and fusion. The second grade is fusion. Third grade is stereopsis. So first is the first picture, as you can see, there is a parrot and its cage. So one eye sees cage and one eye sees parrot, and you fuse that image, and you'll see this simultaneous macular perception. You see this the parrot in the cage. Whereas in the second grade, which is you see one side rabbit and the other side rabbit with a carrot or something. So if you fuse, it will be the rabbit with the carrot. But stereopsis is entirely different. There will be two dissimilar images. Once you join together, you will get a 3D image. That is 2D, 2D joined together 3D image. That's what we work on, all these VR virtual reality and all, where you would have seen the images will be like two dissimilar images, and once you focus in your VR machine, you will be able to see a stereoptic view. The 3D effect will be there, the depth perception will be there, and this is very important for skilled workers, skilled professionals such as ophthalmologists, vascular surgeons and all. We need the stereopsis a lot. Coming to double vision or diplopia, the prerequisite for binocular single vision is perfect ocular alignment. The eyes should be on the same alignment. So strabismus or any ocular deviation hence may result in diplopia. So one eye is this way and the other eye is this way, then you will get diplopia. So there are certain adaptations in order to overcome this diplopia. The compensating mechanism varying according to the type of diplopia and the age of the individual. So that's what. The first is sensory adaptation, then there is motor adaptation. The sensory adaptation is, as you can see in this picture, the left eye is seeing the blue box and the right eye is seeing a red dot. So because of this, what will have is two images joined together and you will get confusion. Because of this confusion, you can either, two things can happen. One, you can completely suppress. See, as you can see, the right eye is deviated, so the right eye is the problem. What happens is your eye starts shutting, your brain stops getting image from the right eye. That's how it's called suppression, and that leads to amblyopia in children. So that's a very dangerous thing. The second thing is anomalous retinal correspondence. That is, instead of having a foveal vision, the blue box that's seen in the left eye, that is captured on a area next to the fovea. So it will get a proper image, and slowly by steadily the macular's place is taken over by the other part of the retina. So as you can see, is a condition in which non-corresponding retinal elements, that is other than macula, acquire a common subjective visual direction in the presence of a small degrees of squint. So small degrees of squint, you will have this problem. This is like small degree of adjustment that happens in your eye. Then coming to motor adaptations. There is something called compensatory head posture, occurs primarily in children with congenital abnormal eye movements who use the CHP, that is compensatory head posture, to maintain binocular single vision. That is, the patient might do chin up, chin down, face turn, right, left, or they will have tilt, face tilt. So about the face tilt, we will talk about it later. For let's say horizontal muscle palsy, that is such as lateral rectus, there will be face turn. This patient is like having face turn and other issues also, but basically there will be face turn alone. And coming to vertical muscle palsy such as superior rectus or inferior rectus, there will be chin elevation or chin depression. But isolated superior rectus, inferior rectus palsy is very difficult to happen. But lateral rectus palsy, as I showed you, it can happen in the case of sixth nerve palsy. So coming to oblique muscle, for oblique muscle palsy, there are such as superior oblique, a patient develops a head tilt, compensatory head posture in right fourth nerve palsy. The patient is having a head tilt in the case of right fourth nerve palsy. In neurophthal, we will completely cover all these nerve palsies together.